Good afternoon, and welcome to this edition of HDSA and Me. Today, we welcome Drs. Jackie Bainbridge and Michelle Atkins from our HDSA Center of Excellence at the University of Colorado. They'll be talking today about medications and supplements and how to prepare for your next clinic visit. You can send a question at any time during the presentation. Just click on the chat function in the toolbar, type your question, and hit enter. Your question will be answered at the end of the session. This presentation will be available in about a week on HDSA's YouTube channel. On May 13th, HDSA will welcome Dr. Martha Nance, who will begin a three-part series on Huntington's disease. You can register for that session by going to hdsa.org/HDSA-ME. And now a little about our speakers. Dr. Jacqueline Bainbridge is a professor at the University of Colorado and Schultz Medical Campus, where she holds joint appointments in the Skaggs School of Pharmacology and Pharmaceutical Sciences, Department of Clinical Pharmacy, and the Department of Neurology in the School of Medicine. Dr. Bainbridge received her doctorate in pharmacy from the University of Colorado in Denver, where she subsequently completed a specialty residency in neurology. Dr. Bainbridge is a frequent lecturer on topics of neurologic and pharmacologic interest, including chronic pain disorders, epilepsy, migraines, movement disorders, MS, neuroprotection, restless leg syndrome, Huntington's disease, and the administration of cannabis for therapeutic intent. Dr. Michelle Atkins received her Doctor of Pharmacy degree from the University of Florida and is currently completing her clinical neurology research fellowship at the University of Colorado and Schultz Medical Campus in the Skaggs School of Pharmacy and Pharmaceutical Sciences under Dr. Bainbridge. Dr. Atkins is actively involved in clinical and didactic activities focused on neurological conditions such as restless leg syndrome, multiple sclerosis, epilepsy, migraine, neuroprotection, chronic pain disorders, sleep disorders, and movement disorders. Dr. Atkins also assists in clinical research evaluating the therapeutic potential of THC and CBD in neurological disorders and chronic pain. We're delighted to welcome Drs. Bainbridge and Atkins here today, and I'll now turn the broadcast over to them.
Thank you so much, Deborah. Dr. Atkins and I are so excited to address this population, so I thank you all for inviting us here today. So next slide. Our presentation today is going to talk about you can go back a couple, Michelle, sorry. Medications and supplements and how to prepare for your clinic visit. So although our background is pharmacy, so we're pharmacists, and pharmacology is what we do on a daily basis, and we have specialty training specifically in neurology, we are not going to be giving you an in-depth presentation on medications and supplements, but more so an overview in order to show you how we help our team in the Centers of Excellence at the University of Colorado Hospital. So next slide, please. So our outline today, we'll start off with talking a little bit about clinical neurology, pharmacy and pharmacist role in our clinic, medication considerations, some side effects that we commonly see, again, not all inclusive, and herbal medications, again, some that we commonly see, again, not all inclusive, the use of how patients in our neurology clinics are utilizing cannabis, what products are available. I'll talk a little bit about which ones are FDA approved and synthetic, and one product that we have on the market that is actually a product that is not a synthetic, but derived from the cannabis plant. We'll talk a little bit about clinical trials specific to Dr. Seeberger and the University of Colorado, and then we'll give you some time for questions and answers. Next slide, please. So let's talk a little bit about what our role looks like in our Huntington's clinic. Next slide, please. And I will say our clinic is very well attended. It's a multidisciplinary clinic. So we have many providers that attend clinic with us. So we have psychiatry, we have social workers, we have spiritual care, we have residents, neurology, MD, and DO residents that are with us. Generally, I come with an entourage. So not only is Dr. Atkins with me, who's completing a fellowship with us, but I will also generally have students that are in the 3rd or the 4th year of their pharmacy experience. So we have a very diverse group, and I think that's a safe way of looking at a patient's care and taking care of the patient holistically, so from head to toe. So some of the things that we do, and you may not be aware of all of these functions. So pharmacists, I'd like to say, are sometimes overtrained. We do a lot of, we wear a lot of different hats. So after this presentation, I'm on my way to assist with giving the COVID-19 vaccinations. Our pharmacists generally, whether we're talking about in our clinic, so the clinical pharmacist, clinical pharmacist specialist, excuse me, or you're talking about your pharmacist that is at King Soopers or CVS, all of us are capable of doing medication regimen reviews. So what does that look like? One thing that we do is we, before we get to clinic, we look at your medication regimens and some of your problem lists. So we look for duplication of medication therapy. So are there medications that are really doing the same thing? So the mechanism of action is the same or similar. We would use these specific medications to treat the same condition. And sometimes that happens if you have multiple prescribers, or you have the situation where some of your medications come from a mail order pharmacy and some of them come from another distribution site. We also look very intently for drug interactions. So we look for drug interactions that are either drug-drug interactions or drug interactions that specifically can interfere with the disease state or even laboratory monitoring. We do something called medication reconciliation. So again, that's where we're screening all of your medications, looking for these interactions. We're looking for also your laboratory assessment. So how is your kidney function doing? How is your liver function doing? The liver is the powerhouse of the body. That's how we metabolize most of the medications in the world. And so how are those all functioning? We actually lose log linear organ function starting in early 40s to mid 40s. So we look for that because a lot of times our medications can be adjusted if you're of advanced age. We can give them less frequently, or sometimes we can give a lower dose. So we're always looking for those medications that can be reconciled. And we're looking for medications that potentially could be recommended, or a good replacement medication that can that might meet some of the needs that a specific patient has. So we assist our neurologists in pharmacology inquiries to really promote what we call personalized medicine or individualized medication therapy. So Dr. Seeberger and our psychiatrists will ask us specific questions, like what might be the best medications to treat this or that. We'll also talk about potential medication side effects and how to avoid or reduce drug-drug interactions. So we try and pick up on that before they actually happen, so we know how to best adjust your medication therapy. We assist also with cost-benefit analysis of medications, And then, of course, we do have a slotted time where we actually go in and visit with the patient in clinic. And we'll ask the patient specifically, or ask you all about what medications you're taking, ones that are prescribed for you. So we'll make sure that that matches what we have in the computer. We'll also ask you about over-the-counter or OTC products that you take. We'll ask you how often you take them. Is it hard? Does anything make it hard for you to take your medications? And specifically, we'll ask questions that you may have about your medications, and we'll give you our contact information in case something comes up along the way. Feel free to reach out to us. So you may not know all the behind the scenes things that your pharmacist can do for you and help with your medication journey. Next slide, please. We'll now turn this back over to Dr. Atkins, and she'll talk to you a little bit about medication considerations. Again, not an in-depth dive into medications, but a brief overview, just a few reminders for individuals, and then she'll talk about some herbal supplements. Go ahead, Dr. Atkins, take it away.
Thank you, Dr. Bainbridge. So I'll be going over a few aspects of how pharmacists can help in an HD clinic, especially with all the nuances involved with medication management and how pharmacists can play a crucial role in helping patients manage their medications. A big part of what a clinical pharmacist does is conduct an in-depth evaluation of a patient's medications. In HD clinic, first and foremost, we need to make sure that the med is working for its intended use. A big part of HD, especially with the disease progression, is the management of chorea. And the most common medications used are dopamine regulators, antipsychotic medications, and other medications such as amantadine to help with the management of chorea. There are some caveats with each of these medications. For example, with the dopamine regulators like tetrabenazine and deutetrabenazine, pharmacists can be useful at identifying pharmacokinetic profiles of these medications and help with dosing. For example, tetrabenazine twice daily isn't as efficacious on a pharmacokinetic standpoint as 3 times daily. We're also able to help with administration considerations. For example, tetrabenazine can be crushed and mixed with water. We're also able to help with coverage gaps as depending on what insurance provider you have and what their drug formulary looks like. Some of these drugs can be limited on coverage based on the max dose that's being used or or the quantity that's being dispensed, and we're able to help with that as well. Additionally, with switching between tetrabenazine and deutetrabenazine, we're also able to help provide recommendations to the provider on the dose conversions between these 2 meds. There's also another medication that is currently in clinical trials for HD. They're in the phase 3 trials called Valbenazine. The brand name Ingrezza is currently approved for tardive dyskinesia, but that might also be another medication that we might see in the future. Other medications that we use for the management of chorea is antipsychotic medications such as risperidone, quetiapine, aripiprazole, and these help. They're supposed to have neuroprotective properties such as mitochondrial preservation. It improves Huntington protein clearance, as within this disease states, it accumulates in the brain. And there's studies indicating that it could help with striatal preservation, which is involved in memory, cognition, and voluntary motor movements. So the caveat with these medications is that there are a lot of side effects associated with them, which we'll get more into, and a pharmacist is able to help at least try to limit the amount of side effects or the severity of side effects a person may experience. Another medication that we see frequently is amantadine. can be used for the management of chorea, but also if there are any cognitive changes, specifically apathy. And like our other medications, it has side effects as well. For example, hallucinations or behavioral changes that we can help your provider with managing the doses or whether or not it's an appropriate drug for you as a patient. Other medications that we see pretty often in HD clinic is antidepressants. They're used pretty frequently as, at least in the beginning of the disease state, psychiatric changes are the first to present, such as depression or lack of attention, anxiety or irritability, and these might be the first medications that are prescribed. But additionally, a lot of these medications that we use for the treatment of chorea can also cause depression as well, such as tetrabenazine or deutetrabenazine. And finally, we also see mood stabilizers such as valproate, carbamazepine, and lamotrigine, which also have quite a hefty side effect profile that your pharmacist will be able to help with managing. Like I said prior, there are many side effects associated with these drugs, and occasionally when a patient presents to clinic, it could be related to a side effect, and pharmacists are useful at identifying this interaction and are able to at least prevent additional therapy or unnecessary therapy that is prescribed because of the side effect. So with our mainstay therapy, common side effects are listed. With the dopamine regulators such as tetrabenazine, deutetrabenazine, like I said, it can worsen or trigger depression or other psychiatric conditions. It also can result in insomnia, fatigue. There's quite a bit of stomach discomfort associated with nausea. Occasionally, it could interfere with bowel movements in the way that you can have diarrhea or constipation involved as well. With the antipsychotics, you can see metabolic changes such as weight gain. Some of these medications have more sedation that can, as a side effect than others, such as quetiapine, and pharmacists could recommend dosing that at nighttime to help with sleeping, especially if there's insomnia associated as well. Dizziness, insomnia are also an issue with these medications. Also, pharmacists will be able to help with dose adjustments or recommendations if a patient presents to clinic with extrapyramidal symptoms or akathisias. And as well with the antidepressants, they each have different side effect profiles and patients respond very differently to all of them. But common ones are nausea, loss of appetite, irritability, dry mouth, sedation, insomnia when you first start it, especially with Prozac, you'll see more activating side effects versus the other medications. All of them have some effect on the QTC interval, which we need to monitor as pharmacists and as providers, and select medications that would at least have the least effect on QT prolongation as well. With cognitive changes, it's important to distinguish between is it related to the disease progression or the medication? And we can look at side effect rates with the medications that a patient's currently on, if there's any drug interactions that would be synergistic at impacting cognitive changes. And we can also see if there's like any sort of temporal relationship between when a patient's taking a medication or when they started a medication and any cognitive changes involved with that. Additionally, with other medications that are commonly seen in HD clinic as well, we're able to identify medications that won't be exactly proper for a patient, for example, anticholinergics that are used in bladder dysfunction, that can have more profound side effects in older patients over the age of 65. Additionally, with benzodiazepines that are used for anxiety, that can also lead to increased sedation and puts at least older patients more at risk for falls, especially in this patient population. A lot of the drugs used for insomnia, particularly the Z drugs like Ambien, are not particularly advantageous to use in this patient population, as side effects such as next day drowsiness, fatigue, sedation can affect patients in terms of their daily activities such as driving, and we're able to at least make recommendations on those. So many of the drugs, like I said, have QT prolonging properties, and this is a concern as QT prolongation can lead to cardiac arrhythmias, and so increasing QT prolongation is something that we're trying to minimize. Symptoms that manifest from QT prolongation involve fainting, palpitations, seizures, and a lot of the drugs like the antipsychotics, tetrabenazine, deutetrabenazine, the antidepressants can prolong QTC to different degrees. For example, with the antidepressants, citalopram and escitalopram have probably the greatest effect on QT prolongation, and should probably be avoided if that is a concern. And additionally, at least in the state of Colorado, cannabis and CBD use is legal, and sometimes patients can use that. And it's important for pharmacists to at least ask the correct questions in order to see if that would also affect drug management. So physicians and pharmacists use caution and monitor for QTC prolongation when the QTC prolonging drugs, when using QTC prolonging drugs in patients with greater than one risk factor, for example, advanced age, metabolic issues, electrolyte disturbances, or like in this case, concurrent use of multiple QTC prolonging agents. Another consideration with a lot of the medications used in HD is that they are either substrates of CYP2D6 metabolism or they can inhibit it. Tetrabenazine and deutetrabenazine, as well as a lot of the antipsychotics, are substrates to CYP2D6. And when patients are prescribed antidepressants, such as fluoxetine, paroxetine, or bupropion, those inhibit CYP2D6, and hence they increase the concentration of the other drugs like tetrabenazine or deutetrabenazine and the antipsychotics, and with the increased concentration leads to increased risk of side effects. Additionally, pharmacists are able to help, especially with the identifying interactions with the over-the-counter products, for example, cimetidine or diphenhydramine or Benadryl, and ranitidine are weak inhibitors of CYP2D6, and at least pharmacists are able to identify that and monitor it for future. So part of our intervention, when we do notice that there is a strong 2D6 inhibitor, is that we can provide recommendations to provider to adjust the dosages, especially with tetrabenazine and deutetrabenazine. For example, tetrabenazine, if used with, say, fluoxetine, has a max dose of 50 milligrams per day and 25 milligrams per dose, whereas deutetrabenazine has a max of 36 milligrams per day or 18 milligrams per dose. As on the tetrabenazine FDA label, they do recommend that CYP2D6 genotyping is recommended if the dose is exceeding 50 milligrams per day, and pharmacists can help provide that information and be involved within that process. Additional side effects can happen in this patient population is insomnia, as that is a side effect, at least for tetrabenazine and deutetrabenazine, and pharmacists can help with optimizing the medication regimen, and as well as counsel patients with improving sleep hygiene, as that is the first line for insomnia. We're also able to identify medications that wouldn't be, that are more so a precaution to use in patients with REM sleep behavior disorders, which can occur in HD. For example, medications such as the Z drugs like Ambien, Lunesta, or medications that target orexin pathways such as Belsomra cannot be used in REM sleep behavioral disorders, and we can provide safer alternative recommendations for that. Additionally, some patients present with swallowing difficulties, and a lot of medications can't be crushed or chewed. For example, if they are extended release or if they are enteric coated, they should be left in their original form, or else the drug won't work properly. For example, deutetrabenazine actually has a controlled release coat and cannot be crushed, although it's not explicitly stated in their FDA label that it has a controlled release coat. And some capsules can be opened and sprinkled with food, and pharmacists have the are able to identify which medications can be sprinkled on food. Additionally, we're able to help with feeding tube compatibility and provide recommendations on whether or not a medication can be used through a feeding tube. For example, deutetrabenazine cannot, whereas tetrabenazine can. And additionally, if patients present with any sort of GI or gastrointestinal discomfort, such as constipation or diarrhea, sometimes that's related to the dose of tetrabenazine or deutetrabenazine. It could be too high, and we can reduce the dose or increase or change at least the dosing schedule of tetrabenazine. Additionally, with tetrabenazine, you can take it with or without food, and that can also help improve the symptoms in these patients. The caveat with deutetrabenazine is that it must be taken with food because how it's formulated, it has very narrow gastric parameters. It requires a very specific pH, and food is required in order for the drug to be optimally absorbed. Side effects such as dry mouth. Pharmacists can recommend a lot of over-the-counter products. For example, Biotene mouth rinse could be useful. Additionally, if a patient's presenting with sores because of dry mouth, mouthwashes that are over-the-counter, specifically containing antiseptics and specifically stating clinical grade strength for gingivitis, can be very useful with at least preventing sores or thrush. Additionally, some of these medications, especially the mood stabilizers, can result in rash, and pharmacists can help determine if the rash is medication related or if it was just caused by, say, taking hot showers for too long or using certain soaps. So we're able to help optimize medication regimen on that end. And if the rash is not medication related, then we can also help with over-the-counter selection. So in all, pharmacists are an excellent resource on how to manage side effects and at least identifying them as well. And beyond helping with providing recommendations on timing of medications or when to seek medical attention or to take with or without food, pharmacists can also compound medications into specific formulations that would be best used for a particular patient. So in HD Clinic, there's a lot of medications that patients can take. Sometimes the list can be greater than 10 medications long. And we do help with medication reconciliation, like Jackie said. So occasionally, we can verify whether or not the medications we have on our record is outdated. We can call your pharmacy and see if there's any, what your refills are or your dispense records are, and to fill in any of the gaps that the providers might need in order to make proper recommendations. And we're able to talk to you and sort of figure out how you are taking it versus what we have on file. Again, we're also able to identify when patients have multiple pharmacies as well, and that can be an issue for some of our medication or medical records, where it can only pull in so much data from dispense records. And we're able to at least talk to a patient, figure out which pharmacies they prefer, and we're able to call and update that information on the medical record. We can also help with management techniques, and especially if there's issues with taking your medication on time, or if you forget to take your medication. So there are apps on the iPhone that can be used, and you can also set reminders, save medication names, and it will also provide information on what medications look like. We can help with setting those alarms at the same time every day. We can also recommend strategies for pill boxes. Compounding pharmacies can actually put your medications in a blister pack per day. That can be very useful if you have a lot of medications and you're not sure which ones you take in the morning or at night. And also provide recommendations for missed doses or storage recommendations, like to keep your medication in a dark place that is away from steam, like your bathroom. Or if you forget to take your night dose, we can also recommend taking, placing your medication by your nightstand to help you remember. So this is a couple pictures of the Medisafe medication reminder app. It's free on the App Store, at least for iPhones. But as you can see, you can set alarms, what times you take it, and you can also add medications into it. So it's important that you utilize your caregivers and healthcare providers because as we can help when to take medications and managing medications, it's particularly important when adherence to your medication is very variable. Some days you take it, some days not. Also, discussions with social workers to help determine resources is always available for you. And we can also help you keep an up-to-date medication list as well. As part of the medication reconciliation process, we do provide that list to you, or we can. And overall, pharmacists can help personalize medication, make sure that it's appropriate for you in order to reduce side effects and to ensure that your medications are working as intended. So with the herbal supplements, you can get these over the counter at you can get them at the GMC stores, I believe that's what they're called. But there's quite a bit of them. The data on them isn't particularly good. So it's important to understand that a lot of these herbal supplements do lack the data to establish efficacy. And sometimes they can even be harmful with the medications that you are taking. For example, ginkgo biloba, that interacts with that CYP2D6 metabolism that I talked about in the prior slides. St. John's wort 2 also interacts with the CYP metabolism, and hence, for example, the CYP2D6 inhibitors will increase the concentrations of your other medications and can result in worsening side effect profiles. Long-term use of turmeric can result in damaging your liver, and it also can affect the concentrations of your drugs. And last, coenzyme CoQ10. A lot of people use that for preserving their memory. However, none of the data supports its use. So if we're able to identify this, then we can also find cost savings within your medication regimen. All right, so I'm going to hand it over to Dr. Bainbridge to discuss cannabis use in neurology.
Thank you so much, Dr. Atkins. So the reason that we are bringing up cannabis in neurology is because we get several questions, especially here in Colorado, since we were one of the first states to actually have medical and recreational cannabis. So I'm just going to blow through a few of these slides, and if you have questions, feel free to ask in the chat. Next slide, please. So when we talk about cannabis, and I'm using the word cannabis as opposed to marijuana because sometimes it seems like marijuana is more associated with recreational use than cannabis, and cannabis can be more specific to the medicinal use of cannabis. And there was just a question in the chat, which I'll take now. So what % of our patients are actually using some form of cannabis? I think it's more people start asking about it. Now, the number of patients who are on a cannabis product, I would probably say are maybe a quarter of our patients. And that's the ones that we know of. Our practitioners are pretty good about asking if patients are taking cannabis products, and we certainly ask about that. So when you talk about cannabis, we talk about really chemical compounds. So cannabis is a phytocannabinoid. In the plant, there are more than 400 compounds contained in the cannabis plant. It's actually closer to 500. Over 100 of the cannabinoids have been isolated. We don't know what all of them do. So most often we talk about THC and CBD as the cannabinoids that we know the most about and are most commonly found in the cannabis plant. We also know that terpenes are found in the cannabis plant. So terpenes actually give the nose to cannabis, so the smell or the aroma. Also, some of the terpenes may be used for medicinal purposes. So we know limonene will actually help with some gastrointestinal complaints, but more research really needs to be done on the terpenes and the cannabis plant as well. So cannabinoids and terpenes are found throughout the entire plant. So we're talking about the flower, the stems, the stalks, the leaves, etc. We also talk about indica and sativa. So indica is more, or tends to be more sedating, as my students have taught me. That's Inda the couch. So more sedating, and sativa is more uplifting. Right now, when you go into a dispensary in Colorado, at least, you really find that there's more of a hybrid blend. So it's difficult sometimes to get a pure strain of either one. We know that cannabis has actually been used for a number of years. So the first documented cannabis use for medicinal purposes was back in 400 AD. And cannabis was actually mentioned in the United States Pharmacopoeia in 1850. Later, that was pulled from the USP in, I think, the 1970s. Next slide, please. So THC, or delta-9 tetrahydrocannabinol, is the cannabinoid found in the cannabis plant that produces the high effect or the euphoric feeling. The mechanism is really felt to be a partial CB1 agonist. Beneficial effects that we know of with THC are to avoid nausea and vomiting, especially when induced by cancer chemotherapy. It can promote, appetite, and maybe some other medicinal qualities. We do see side effects though. Short term, we can see a loss of coordination, memory loss or loss of time. You also see an increase in heart rate and heart rate variability, which can be problematic in some individuals. We can also see hallucinations, delusions, a panic feeling, paranoia, and also a psychosis. And then long-term effects, you can see that it will have an addictive property, around 9% overall, somewhat higher in the adolescent brain. It can also decrease cognitive or lower IQ scores or impair cognition, especially when you look at habitual use in the adolescent group. We also see a hyperemesis syndrome that can be caused by THC. This is again with chronic use or habitual use. And interestingly enough, and this actually does take a lot of patients to the emergency department, it's hard to get that vomiting under control. Our usual antiemetics don't seem to work very well for this. Sometimes they will, sometimes they won't. Sometimes we'll anecdotally use capsaicin cream on the abdomen. We can also see an acute psychosis that generally occurs when patients will take or overuse some of the edibles, because the edibles will have a variable bioavailability, and sometimes they have a lag to onset. Next slide, please. Cannabidiol, or CBD, which has gained much attention in the literature, does not produce a high effect. So it has non-euphoric components of the cannabis plant. The mechanism of action is unknown, although we're finding more out about the mechanism of action. And most of the time we feel like it doesn't work on its own. It actually increases what we already have in our body. And I have a slide on this in a couple slides forward, but we increase the endocannabinoids that we have in our system. So anandamide, or 2-AG, and that will actually affect the CB1 receptor indirectly, so by increasing that anandamide. We also find that research is being done to look more into the mechanism of action, and what has been found is there is interaction with the opioid receptors, G protein receptors, and G protein coupled receptors. And I have another slide on this. Next slide, please. So some of the beneficial effects of CBD is, one, it doesn't produce any vital sign changes. So it doesn't increase your heart rate, and it really doesn't produce overt neurologic effects in terms of being euphoric or causing a high. And we do see increased sedation. Now, many people will take CBD to increase sedation or to help them go to sleep. So some of the side effects we see that we do caution people about is sometimes it will decrease your appetite. So we see some weight loss. It will also increase some of your liver function tests. And sometimes we have to ask patients to decrease their use or stop taking it because of those laboratory abnormalities. It can also cause some diarrhea and GI upset. Next slide, please. We also talk about hemp. So what is hemp? For anything to be considered hemp, it has to be no more than 0.3% on a dry weight basis of THC component. So we can actually see hemp growing outside. Hemp generally is a bigger plant, likes to be outside in the fresh air, and that plant gets really big because we're trying to minimize the THC content. Importantly, it cannot be, again, no more than 0.3% of THC. The THC plants that are grown to maximize, or the cannabis plant to maximize THC is grown indoors. And those plants are babied, the temperature is controlled, the lighting is controlled, et cetera, because those plants you want to stay relatively small and maximize the THC product. So hemp, very different. And Yes, next slide, please. These are just some of the differences. You can look at this slide later on, the differences between hemp and marijuana or cannabis. So again, you don't see psychotic properties or euphoria with the hemp plant because it contains no more than 0.3% of THC. Next slide, please. This is our map of the United States, and this changes on a regular basis. So you actually can see that we have many states that have legalized cannabis or marijuana. Some places only have medicinal use or medical use, and some places have both. Next slide, please. This slide is just summarizes what is on that more busy map of the United States. So basically just with this last election, you can see that there are many more states that have entered into the recreational or legalized use of cannabis. What the laws look like in those states, yet we don't quite know yet. Virginia was one of those states, New York, another one. Next slide, please. With this particular slide, you see a number of states in parentheses that actually have various approved medical conditions. This is the information that actually goes to states for them to provide legislation on which conditions potentially may be helped by using cannabis. And these numbers, again, change all the time. Some states will actually have Huntington's disease on their registry to be helped by cannabis and to give that guidance to the state. Next slide, please. What we don't know and what many consumers don't understand is that much of that information in many of those states really are using small clinical trials or case reports to extract that information and provide legislation in various states for medical conditions in which cannabis may help. So, so really the current legislation is misleading. So we know that cannabis might help symptoms of dementia, or depression or glaucoma, but it's not going to cure those conditions. So it may alleviate those symptoms, but not be curative. And we do need more clinical trials that are robust, that tells us and gives us the answers that we need as to whether or not cannabis is efficacious in these particular conditions. So consumers need to know that that's not based on a lot of science for which our states are given legislation for the use of cannabis. Next slide. So our available cannabis products, next slide. There are several FDA approved cannabis products. So Marinol or Dronabinol was actually FDA approved in 1985. It's a synthetic THC. It's currently a DEA Schedule III, and it's used for patients who have anorexia associated with HIV or AIDS. It's also given for nausea and vomiting associated with cancer chemotherapy. Most recently, Epidiolex, which is cannabidiol, is or was FDA approved in June of 2018. It's actually plant derived from the cannabis plant. So they extract the CBD. It's purified. So we know exactly what's in that bottle. We know there's 100 milligrams per ml. We know all the components within that particular product. So much different than what consumers can purchase online at a grocery store or gas station or at a dispensary here in Colorado. So it's purified and it's plant derived. It's FDA approved for Lennox-Gastaut syndrome, Dravet syndrome, and tuberous sclerosis complex, which are all different forms of epilepsy. Next slide, please. Sesamet or Nabalone was FDA approved in 2006, and this is another synthetic cannabinoid. It's It's a Schedule II and also used for nausea and vomiting for cancer-related chemotherapy. Sativex is not approved in the FDA as of yet. It is a about 1-to-1 THC and CBD product. It is licensed in many other countries, though, for multiple sclerosis related spasticity and other spastic conditions. So it's, again, not FDA approved yet, but clinical trials will be starting at the University of Colorado soon in multiple sclerosis, though. Next slide, please. So basically, when you look at cannabis activity at the receptor level, basically we think about, and this is really when you talk about THC effects, it has different varying effects in different parts of the brain. So when you talk about hitting the hypothalamus with THC, you get a good effect or a positive effect for many patients, and that increases appetite. However, if you look at what happens to the nucleus accumbens, you see euphoria, and that's where you get that high effect. And in the hippocampus, you can get memory impairment and so forth. Next slide, please. When you add, you can go to the next slide, please. When you add in the effects of CBD, you actually see that you decrease some of the effects that you actually get with THC in those particular areas of the brain. So it'll decrease some of the euphoric effects or bad effects, potentially bad effects of THC. Next slide, please. We know more about the dosing of THC, less about the dosing of CBD. So if you're consuming a product, a CBD product, I would say I would take less than the manufacturer recommends on the bottle. Maybe start with 1/4 of the dose and work your way up to see what effect you actually get. Now, I mentioned earlier on the endocannabinoid system. This is what we actually have in our body. And the whole reason that the endocannabinoid system exists is to maintain homeostasis. So a friendly place in the body. And we see this throughout the body. So the body produces these endocannabinoids, which I've mentioned briefly, that will actually be elevated when someone takes CBD, and that indirectly binds to the CB1 receptor. The CB1 receptors are mostly found in the central nervous system, so the brain or the spinal cord. CB2 receptors are found mostly in peripheral organs, especially immune cells. So they help to regulate immune responses. Next slide, please. And when you look at trends across the board of who's using cannabis, you actually find that the largest group of patients consuming cannabis products are anywhere from 18 to 25 years of age. But you also see over a lifetime, we're actually getting into individuals who are beyond the age of 25, so more of advanced age. Next slide, please. On average, we find that the mean age or the average age of patients consuming or people, individuals consuming cannabis is about 45 years of age. 55% were male, major league in the Caucasian group. 67% of patients reported cannabis experience prior to seeking medical validation of using it or whether to use it in their particular condition. Primary medical conditions are chronic pain, anxiety, PTSD. About 14% of Americans say that they've at least tried or used CBD products. Most of the time they're using CBD products for pain, and 20% for anxiety and 11% for sleep. Next slide, please. Cannabidiols, I've already mentioned this particular product is fairly new on the market. The interesting thing is it comes directly from the marijuana plant or cannabis plant, and then CBD is extracted. So much different than we see from our dispensaries We've already talked about what it's FDA approved for, and it was Scheduled 5 by the DEA, so controlled, but now it is no longer scheduled, so it's descheduled. There is a little bit of THC in this particular product, so some patients can test positive for cannabinoids. The side effects we've already talked about, but you really have to be cautious of GI effects, gastrointestinal effects, sedation, and liver function tests increasing, and weight loss. Next slide, please. Precise mechanism, if you look in the package insert, is unknown. Next slide, please. However, there's newer evidence that CBD will potentially block the GPR55 receptors, desensitizes the TRPV1 channels, and inhibits adenosine reuptake pumps. So all of this will decrease neuroexcitability by decreasing calcium and increasing intracellular adenosine. These mechanisms are fairly important in at least Parkinson's disease and probably epilepsy as well. Next slide, please. So basically, these are just some of the side effects that we see with Epidiolex. We've already talked about increasing the ALT and AST, which are liver function tests. Next slide, please. There are drug-drug interactions that we do screen for on a regular basis with Epidiolex, and we use this information that we have from clinical trials, and that is also what makes Epidiolex different from what we have in a dispensary. So we can utilize what's in this package insert to make decisions about drug-drug interactions and side effects with other CBD products. Next slide, please. This is just more on the drug interaction piece. You can review that for your edification. We take care of that on our end. Next slide, please. So in summary, when we're just talking about the cannabis piece, prescription cannabis-based products go through rigorous clinical trials, so a regulatory process, making sure that they work for a specific therapeutic indication. We know what the ingredients are, there's standardized dosings and formulations. When you look at OTC cannabis-based products, there are no clinical trials or oftentimes very few and not well regulated. Really no specific indications. Those particular products should be used for health claims on the label. All of the ingredients may not be known and may not be consistent. So you see variation between products, and that actually has been documented. Next slide, please. So some of our clinical trials that I'll just state briefly that are going on at the University of Colorado in our Center of Excellence for Huntington's disease. Next slide, please. And these are with Dr. Seeberger being the lead investigator. We have the Kinetic HD, which is Valbenazine used for Huntington's chorea. It's a large clinical trial. It's currently in phase 3, which is the last phase before it goes to regulatory overview. These are randomized controlled trials. They're double-blind placebo controls. The product is taken once daily for 12 weeks, at least in this phase 3 trial. We also have the State of Colorado UPL grant for telehealth and rural frontier in the underserved patient populations focused in on Parkinson's and Huntington's disease. Next slide, please. So our overall summary is your pharmacist can be a valuable resource. We'll start with that. Pharmacists are a valued member to the healthcare team. We do and participate in medication reconciliation, provide recommendations to providers, assist with medication dose adjustments, identify drug interactions and medication-related side effects. We help patients manage their medications, select safe over-the-counter products and options, and improve ways to be adherent with your therapy. Currently, Epidiolex is the only FDA-approved cannabis product on the market to treat severe types of epilepsy. Clinical trials and additional research is needed, not only in Huntington's, which we're working on that, and cannabis. And we're trying to work on that, but it would be helpful if it wasn't a Schedule 1 by the DEA. Next slide, please. At this time, we'll take questions, and I do think we do have a couple questions in the chat box. And I apologize, I think we were really pretty chatty here. Lots of good information to give you all. So in the absence of an on-site pharmacist, who should HD patients and caretakers talk with about their medications? Since supplements are not regulated, what should consumers look for when choosing a specific brand of supplementation? So let's take that. I would look for that stamp of approval. So GMP type products. So one of those manufacturers would be Nature's Made. So the FDA will come in and regulate the plant, and at least you know what active product is in that particular capsule or product that you're getting. So, and Michelle, remind me, what is that stamp that is on those bottles? It's just escaping me.
The CGMP, right?
Yeah, but there's another stamp too that's on there. It's on Nature's Made. Think about it, and I'm going to move on to these other questions.
I know what you're talking about.
So basically, you can ask your pharmacist wherever you pick up your medication about these particular questions that you may have. And what are the most common supplements used in HTD patients? And are there any supplements in particular that HT patients should avoid? Yeah, Michelle, do you want to take that particular question?
Yes, and the stickers USP.
USP.
Like
Thank you so very much.
At least I think the most common supplements I've seen is melatonin, specifically for sleep. Occasionally I'll see turmeric quite a bit. Let's see, the second part is ones to avoid. Like the list that was on one of the earlier slides, but any of the 4G herbal supplements being ginseng, ginger, garlic, and ginkgo.
Yes, because they call us bleeding.
Yeah, those are notorious for drug interactions as well. Also with the CoQ10, it's more so you'd be just spending more money on something that's unnecessary with no data supporting its use, so may as well just save that money for other things. So
especially when you're talking about treating Huntington's disease or even Parkinson's disease. One of the clinical trials that I participated in and ran, I do a lot of clinical research, many in neurologic conditions, but also in cannabis. And it was found that CoQ10 was not effective for slowing or halting the progression of Parkinson's disease or Parkinson disease. So I think at this time, Deb, I think we are out. Deborah, I think we're out of time. I certainly appreciate everyone's attendance and the ability, it was our pleasure, so the ability to present to you all today and to represent our Huntington's Center of Excellence.
Well, thank you both, Drs. Bainbridge and Atkins. This really was a terrific session. I learned a great deal, and there was a lot of information. This session will be available on HDSA's YouTube channel in about a week, so folks can go through and reread those slides and hear your information again. Thank you so much for this presentation and for taking time from your busy schedule to participate in this session of HDSA in May.
awesome. Thank you.
Thank you.
This time we'll say thank you and have a great day.